serve with you. And as a reminder, we have new meeting.
Senator Alvarado.
Here
I'm sorry.
from the district.
Yeah, the members, you'll need to indicate whether you're present in person or remote from the office. I'm sorry.
Thank you, sir. Senator Berg.
Present remotely.
Thank you. Senator Carroll.
Present in the room.
Senator Storm. Representative Bowling. Representative Frazier.
Present in the room.
Representative Gibbons-Prunty.
Present in the room.
Representative Sheldon.
Here remotely.
Thank you, sir. Representative Weber.
Present in the room.
Representative Westrom.
Here in my residence in 79th District.
Thank you, ma'am. Representative Wilner. Representative Reed.
Here in the room.
Senator Meredith. Chair Bentley.
Secretary and Director.
Yes, sir. This is Eric Friedlander, Secretary of the Cabinet for Health and Family Services.
And I'm Eric Lowry, Budget Director for the Cabinet for Health and Family Services.
Thank you all for having us today. Appreciate the opportunity to present on what we know and some of what we don't know. First, I just want to clarify that what we're presenting on today are really what the Cabinet has received. I saw this as kind of separated into two agenda items, but I hate to tell y'all, but it's kind of together because it's so hard to separate where really kind of the COVID aid begins and where some of this other aid begins. So this is together in one. The other thing I want to make sure, again, just getting us all on the same page. This is the money that's directed specifically to programs. I really can't speak to all of the funding that's coming to state government, but I am able to speak to what's coming to the Cabinet for Health and Family Services and where we are today. Please understand that there is some evolution that is continuing to happen. So even as I describe programs to you, I will be giving you where we are today. If that's helpful to you all, I just kind of wanted to say that from the beginning, because I know I get confused by all the different funding streams, and we get letters. We got a letter today on the water program. So we're still getting award letters and understanding exactly how much we're receiving. So this is, again, I just want to be clear. This is the best to our understanding today. I don't want to do anything other than let you know exactly where we are.
Okay, so your time will be doubled then since you're going to put the two together. So right now we'll start with 10 minutes each.
Okay, thank you, sir. I appreciate it.
Yes, sir.
You all, I think the budget staff is controlling my slides. Is that correct?
Mm-hmm.
So
No.
I have them. Well, I don't know if I have control either. So what I'm going to do is, if you all can follow, I apologize, and I'll tell you what page I'm on as I go through.
Okay.
So we can just go right to page 2, actually, and really it talks about the overall funding, what that looks like. I think we have billion down, but we meant trillion.
Yes.
But this is for everything, right? These are all the different pots that are coming into the state. Obviously, there are pieces here that I cannot speak to, but those pieces that relate to the cabinet, again, we will address as we go through this presentation. But this just kind of gives you the broad scope of the funding that's coming to the Commonwealth. So I wanted to give you all that overview as we started. I'm going to turn it over to Eric for page 3, and he'll take us through page 3 and page 4.
Okay, thank you. On slide 3, ultimately there have been 6 bills that have been passed through Congress to address the coronavirus pandemic that has resulted in funds coming through to our cabinet. Just to kind of compare the American Rescue Plan with the other bills that have come through, the American Rescue Plan provides for $1.1 billion to the cabinet alone, funds that the cabinet will administer. This is quite significant compared to some of the previous bills. The first bill that was passed, the Coronavirus Preparedness and Response Supplemental Act, we received a $7.5 million grant for Department of Public Health. The second bill that passed, we received $3.2 million under the Families First Coronavirus Response Act for home and congregate meals, which we've spent just about all of those funds. That bill was also significant to us because it provided our enhanced FMAP rate, of which we have realized roughly $800 million to date in enhanced FMAP. So that has been very significant for us to address the pandemic. The third bill that passed was the CARES Act. The CARES Act seemed very significant at the time, with $416 million. A lot of money in that bill was directed towards testing, tracing, surveillance testing, some child care initiatives, a whole host of programs. It's kind of dwarfed in comparison to the last 2 bills that have been passed. The Paycheck Protection Program provided $98 million to public health on a lab testing grant, and then the Coronavirus Response and Relief Supplemental Appropriations Act, which came out of the Consolidated Appropriations Act, provided $563 million to the cabinet. A large portion of that was getting into vaccinations, further testing, and some child care dollars. So if you go to slide 4, this provides a list of all the funding to date that the cabinet has received under the American Rescue Plan. As you can see, out of the almost $1.1 billion the cabinet is receiving, roughly $750 million is specifically in child care. The remainder of the dollars are split out amongst multiple programs such as LAHEAP, such as more services for seniors with congregate and home delivered meals, preventive services, family caregiver. There are dollars for mental health block grant, substance abuse block grant. There are also dollars for screenings to help reopening schools. So there's a wide variety of funding. We have not spent any of the American Rescue Plan dollars yet. These awards have just been coming in over the last few weeks. The bill was passed in March, and the actual grant awards have just started coming in. So we anticipate these dollars to start spending these dollars probably in July will be the first expenditures that we'll have. So I'll turn it back over to you.
All right, and we'll head to page 5 to talk a little bit about some of the specific programs and where we are with planning and what our thoughts are currently. And again, these are all, as Eric talked about, you got 2 Erics, so we get to blame each other when we make a misstatement. But so what we're talking about now are sort of how we're discussing what our plans are. I don't think there should be any surprises to anybody in the field at this point. At least I hope not. That's not our intent. So we just want to make sure you all understand where we are. So with that, the Child Care Development Block grants, really the top priorities in there are going to be some support for subsidies. We, for years, I think you all know, I used to be over the place that's called the Office of Children with Special Healthcare Needs. We really need to look really strongly at what we're doing with kids with disabilities. And so we're going to be able to use some of that funding to, we hope, to support some of those programs. You know, really work on our pipeline of professionals coming into the system. The stabilization, the child care stabilization, we're going to send that out as payments to child care providers. Obviously, they need the support. This is really targeted towards some special salaries, some fixed expenses, you know, some of the facility needs that really, you know, that kind of really more, it'll be dispensed out to the child care centers, but we're really hoping to, you know, really build up and support from even an operational standpoint, those facilities. The child care match increase, that's really pretty typical. That's the matching funds that we'll have and the child care subsidies that we have through that match enhancement, which is, again, good. It'll help support our providers. The LIHEAP program, has been mostly the weatherization and help and assistance with utility bills for those who need assistance. That is administered primarily through community action. My brief stint in Louisville, I was over the community action agency there. And what we'll hope to use these funds for, we may be able to look at some eligibility limits, maybe very limited, but the other big thing we're thinking is provide some support for a summer cooling program. As you all know, some of the heat waves we've seen in recent years have had some really negative impacts on our population, particularly those folks who are elderly. So we want to make sure that we're providing some support during the summer months as well. Pandemic EBT, we are going to examine if we can, what that summer pandemic EBT needs to look like. We need to put a plan into the federal government, but similar, I think the last EBT, pandemic EBT piece that we did, I think that, you know, we learned, I think, each time, so we're going to continue to learn. And we're also going to see if we can look at maybe a 0 to 5 option to help support some of our infants and toddlers. The emergency assistance, that is really those folks who receive our Kentucky Transitional Assistance Payment Program, maybe some additional support there, looking at hopefully some creative ways that we can use those funds. And then in adult protective services, we're working again through community actions. They've been a great partner, and we'll continue to partner with them. So community action, that's LIHEAP, that's some of this protection service program for some additional funding for folks to be able to support people in the field and particularly vulnerable adults. And then child abuse prevention. Those are all our primary and secondary child abuse prevention programs. We'll be able to fund them a little better, and hopefully you will see some of the fruits of that labor as we move forward. So that's been a way that we've been able to, in some ways, decrease our out-of-home child care, and we're going to continue to try to do that. It's really important. That prevention, primary prevention, focus on supports for those vulnerable families. You know, a kid, if at all possible, is better off with their families. You know, that's something that we're going to focus on. And if we can support the families and strengthen families, that's exactly what we want to do. Those are the right decisions that I think we should all support. And then the captive funds, the child abuse prevention treatment, those are how we come up with some of the intake pieces, again, with some of our partners. and make sure that we are doing things that support our communities and our children who are, we know, coming out of the pandemic, we're going to see, I don't think there's any question, increases. We saw a decrease in our reporting when schools get back in, when communities open up, which I'm very excited about. The negative side of that is we're going to see some behavioral health issues and substance use issues, neglect and abuse issues. There's no way that that's not going to happen. So we need to be prepared for that and be prepared to support our communities as we move forward. The next page 6. I'm sorry, I'm going to try to speed up. Our senior supportive services, our congregate meals. We work with the area aging AAAs is what they're called, and they're really through our ad districts, associated with our ad districts. We've been really, I think it's a powerful thing to say that we have actually been able to eliminate any waiting lists for folks who need food, probably since over a year's time. We've provided at least an additional 1 million meals to seniors. We're still up in terms of percentages on providing meals. There are lots of great stories there. I know Commissioner Anderson would be excited to present about really some of the creativity, right? This is not about us. This is about the creativity that's come through communities, restaurants that helped out, food producers that helped out, that really made a difference in our communities to address some of the feeding issues within our senior population. We will also then use some preventative services. Again, those are exactly what they sound like. Some family caregiver supports. We know that there have been some real challenges there. I could attest to that personally. And then some additional funding for our long-term care ombudsman, who've been really important in making sure that as they work with facilities and families, that they know what they're going to see in these long-term care facilities moving forward. So those are really critical and important areas for us. The next page, on page 7, these are our block grants. These are additional funds, again, for the behavioral health, mental health, and substance abuse block grant. These are important programs for by and large. These are dollars that we use and we partner with the community mental health centers across the Commonwealth. And these funds support those efforts. So, it really does look at treatment services for those who are uninsured. And then really some of the pieces that we've been doing around evidence-based and best practices, again, goes back years now. What those programs and which ones have been effective, and how do we support more services in our communities? And we are looking into that, particularly around pilots that we then may be able to fund using Medicaid as our partners. So those are, again, as I said, coming out of COVID, we know we're going to see more. We've seen some unfortunate spikes throughout our programs. So we know we need to be prepared for that. In terms of public health, some of these grants really start. So the Health Equity Vaccination Grant, we just put that in and just received notice that we would be receiving, I think, yesterday, day before.
Yes.
So all of this is pretty new. The school screenings, there should be, I don't know if I get to say it, but been working on an RFP. We hope to have it out very soon on really folks being able to provide services to schools. The home visiting program, we know that we've had some learnings through this pandemic and what's best virtual and what's best in person, and how to support all those options for families and kids. And this funding will help us do this. And then this public health workforce initiative, I think we've all learned, I think, how important our public health departments are in responding to all sorts of diseases. And so this is to support that workforce moving forward. We've got to support all the career pipelines, which a lot of these funds address, where we have shortage in providers. And again, that's true from childcare to behavioral health to substance use to public health. We need to make sure that we provide career pathways for folks so that they can come and help us when we need to respond in a crisis, and in some of these where we need to respond in general. That's a very quick overview, and I think I just made it within my time limit.
You did very well. Thank you. Very good presentation. And now we'll have, I want to thank you for your presentation, Secretary, and Mr. Lowry, too. For those members with questions for our presenters, we'll take questions from the members here in the room first. So, you got it. Okay, Representative Prunty.
Thank you, Mr. Chairman. I have a few questions.
Yes, ma'am.
Thank you, Secretary, for your presentation. On slide 5 on the child care stabilization, could you elaborate a little bit more on how specifically those funds are going to be used besides just sending money out to the facilities?
And getting there. So basically, all the child care facilities, including certified, licensed, and registered. There's actually really, I'll take 1 second and tell you a good story, and then I'll come right back to your question. We've been able to supply some one-time funds for those really small child care facilities. We may, at the end of this, end up with more of those kind of certified, really small family homes sort of things. We had a deficit in that. We really are making an effort, because I feel very strongly that it's an entrepreneurial path, right? We're going to try to support folks opening up small businesses, and this is one way to do that. Not necessarily with these funds, but these funds can free up some more so that we'll be able to provide some support to folks to begin to open some centers. So this can go for salaries. This can go for fixed expenses. We're going to ask for some of that, again, for the behavioral health side of it. Some support for training for providers, particularly around social emotional health for these youngest kids going in. We know we're going to see some increasing needs for that. And then some of this money can go for some of the supports, right? If they need some PPE supplies, some additional supports, and maybe even some structural changes to allow some better ventilation. So again, these are the kinds of funds that can support some of these providers, and that's what we will be using them for. Does that help?
Yes. And Mr. Chairman, can I continue with another question?
Yes, ma'am.
You mentioned in the Pandemic Emergency Assistance, the TANF funds, that you might have creative ways to support. Can you elaborate what those creative ways would be? And I guess the reason I'm asking is, would they be creative ways? Because I'm for keeping the families together, family first, and that sort of thing. But are they empowering creative ways, or are they enabling creative ways?
So, like the childcare, right? We did that little experiment with there. I really want to figure out, and this will be a discussion, right? Because it's not something we can make up out of whole cloth really quick. But I want to encourage entrepreneurship. I want to encourage folks to be able to, there's some, it's called micro business, right? How do we encourage that? Because I think some folks will have the opportunity to start some of these really small businesses. But my experience when working in community action in Louisville, they needed support to get to a place where they could be entrepreneurs. Understanding that folks need a checking account, understanding that the credit score is important, and then providing that support, that beginning support, either through a grant or repayable loan, and there are reasons to do both of them, to really help folks who want to begin that small business. And I think the tricky part there is that handoff from that kind of micro business to getting something a little bit bigger. But we want to encourage as much as we can, and that's the creative piece that I wanted to talk about with these funds, is looking at how we can encourage the creation and support of folks who may have some micro business ideas. And so we want to figure out how to use these funds for that. The other thing that we want to look at is then how we are able to use these TANF funds. And I think there's a study group on this, so I might be tipping my hand, but it is then how do we use these funds like in support with some of our SNAP education and training funds, again, to support some of that career pathway, because we really want to get people thinking about that. And if we can get them to an entrepreneurial space or in a career pathway, that's what we want our focus to be. It's going to take a little tweaking of our programs, but that's something I look forward to talking with you all about and presenting. But that's the kind of direction that we're heading in.
Okay, thank you. I like what I'm hearing. So, and last question.
Quickly.
Is there, I don't see it anywhere here, and I don't think it could be hidden anywhere, but could any of these funds been used to support abortion clinics at all from the pandemic? Okay, thank you. Thank you, Mr. Chair.
Representative Frazier.
Thank you, Mr. Chairman. Thank you, Secretary, for being with us today. Providers in the home and community-based waiver program have not received any communication on potential assistance or relief, and adult health care centers continue to be hit very hard. And in fact, Active Day, located in my district in Richmond, announced last week that it was closing its doors permanently. I would like to know the Cabinet's plan to help the adult day health care facilities. Thank you.
Certainly. Commissioner Lee is coming on after me to talk about waiver providers and some of the additional supports that there's an additional some additional funds coming in through Medicaid. We have received some proposals, so I don't want to get too far in front of her, but we've received some proposals from the provider community about how they'd like to see some of those funds dispersed. We're certainly willing and are working and communicating with the communities. They've sent us their proposals. We have proposals from AARP and several others. And again, Commissioner Lee will get into this. We have to be careful because the additional funds at this point are really time limited. So we need to make sure you all passed something for nursing facilities, which really went along with the increased FMAP rate. That's being put into place now. And so we have to be careful about what would be ongoing funds versus some of those one-time funds. But we certainly are looking at that now and hope to, Commissioner Lee will have a little bit more on this, but we're still working on what that plan needs to be.
Okay.
Sorry that it's not a better answer, but it's where we are right now.
Okay, thank you.
Representative Moser.
Thank you, Mr. Chair. Thank you, Secretary, for your presentation. That was pretty weighty, so I know that we've got a lot of things to really dig into. I'll have a lot of questions, and I know we have a meeting later, so we can talk about this. But on the you talked a little bit about the CDC Health Equity and Vaccine Program. Can you elaborate on that and determining eligibility, or what exactly that looks like?
You are going to love this answer.
Oh, good.
We're putting a lot of funds in community health workers. We're going to support around 50 across the state. Again, some as a pilot to figure out what the costs are, so that we can look at what it would take for additional support of that kind of program through Medicaid. We are then looking at what we can do with some of our community-based providers to help support them in their outreach. And that's across the state as well. So those are the two major pieces in there. So it's really about making sure that we have as much outreach into community as we can possibly get. And like I say, a major portion of that is going to be looking at community health workers.
Okay, thank you. Yes, you're right. I do like that answer. It really kind of leads to my next question, if I may. There's so many uses for community health workers. I look forward to really digging into that. On the public health workforce initiatives, is that also looking at community health workers as a career pathway? And then, I know that there are a lot of ways that we can use community health workers. So I don't know if we've considered replacing the connectors with the community health workers, if we have kind of one bucket, if you will, of health assistant, the community health assistants. I know it's complicated because, if we pay for the community health workers with Medicaid, we can draw down federal dollars and then save state dollars on the connector. So there are a lot of moving parts.
There are really the community health workers primarily are in the equity side of this. This is more support for what you might think of as who you might normally see within a public health department, like environmentalists and things like that, as well as then some of that infrastructure support, right? We have several different IT providers. We have realized that we have a little bit of a disjointed system as we've gone through this. We've put it together with us. I like to say duct tape and twine, but we need to come up with something a little more substantial as we proceed. So it really is more focused on that typical pipeline for public health workers in this case.
Okay, thank you.
Does that make sense?
It does. I mean, we've had a lot of these conversations, so I appreciate the ongoing work, and I think it could really help us create a sustainable program. So, especially for navigation. Yeah.
And I think it'll make a big difference for us to be able to do that and to find the ways that we can. This is just about maximizing federal funds, right? So this is what we're going to try to do.
Exactly. Okay. Thank you.
Thank you.
We'll remind those people out there remotely, use their chat function available on your screen, and staff will notify us when you have a question. But right now, we're going back to Senator Carroll.
Thank you, Mr. Chairman. Secretary Freelander, in dealing with the child care, how much thought is going into long-term solutions in child care? We can infuse money, and it's great, and it's badly needed now. I talked to an owner a couple of days ago that has been in the business for about 20 years, and she's about ready to get out, struggling to survive. And the infusion of money and the training, those things are all great, but there is still a long-term issue that we have to deal with, and not just providing funds for entrepreneurs to start a new business, but to set up a structure where they can sustain the business over the long haul. My facility is paid for. During our best times, it loses money. So the issues go far beyond just an immediate influx of funds. There is a long-term structure that we need to address. What input or what are you all thinking in that area?
Senator Carroll, thank you. As you know, that is an excellent question and a difficult one. So the piece on the entrepreneurial piece, also providing some one-time funds for folks who may want to set up through an employer. I think folks understand now better than ever, I think, the importance of childcare to community, to workforce, and how critical that is. The only way I can answer that, some of the support, some of the training support, some of the one-time funding for setting up facilities, and some of the payments that will help defray some of those costs. But the real answer is a continued discussion with you all. The real answer is how we as a state decide, and to what extent we decide we can support our child care providers. I think it's critical. I think if we just depend on federal funds, we're going to be really challenged. So I think it's going to have to be an ongoing discussion between you and us, and then what we do with funding headed down the road, not just federal funds.
Okay, thank you, sir. And just quickly, some priorities. The mask mandate needs to go away. It is having an impact on behavioral issues within child care. And I think at this point it's doing far more damage than it is good. I would recommend as quickly as we can make that happen, it needs to go away. Behavioral health issues, talk to several providers in our area, and I've heard from throughout the state that this is an issue like we have never seen before with behaviors within child care. So that's something that I think needs to be considered. And obviously workforce. Mr. Secretary, there are empty, and I'm sure you're aware, there are classrooms empty all over this entire state. in childcare simply because we cannot get enough employees. There is no incentive for people to go back to work in that pay range, and despite efforts for sign-on bonuses, you name it, it's being attempted throughout the state with very little success. And, we can infuse a lot of money, but if we don't have workers to take care of these kids, it's a wasted investment. So just coming from a provider's perspective, those are the struggles that our facility has, and in communications with throughout the state, it is consistent. And those are some immediate issues that I feel need to be addressed. Thank you, Mr. Secretary, and thank you, Mr. Chairman.
Yes, sir.
Thank you.
Senator Meredith.
Thank you, Mr. Chair. Thank you, Secretary Freelander. You've touched on this a little bit, but just like elaborate a little bit more. A lot of money here. It's kind of like drinking from a fire hose right now. But I'm having a hard time determining whether we're focusing on supporting existing systems or restructuring systems in building a level of care that, while commendable, we may not be able to sustain in the future. And I really, it's no criticism of the presentation today. You guys have done a great job, but I don't have a good sense for that. I really would like to know what we're going to look like post-COVID, like 5 years from now. And everybody's identified a lot of different issues, different providers we know we need to address, but I would like some sense of security that we're not currently building a system or restructuring a system that we're going to have almost impossible to finance in the future by the changes we're making today.
Right. That is another great question. So I will tell you, been in a budget position with the cabinet. I'm very sensitive to we should not commit ourselves to future spending that we can't sustain. I think that's a mistake. But within that, I think we do need to look at how we restructure programs headed into the future and where we can make them sustainable and how we can make them sustainable. I think my hope is, and this gets down a rabbit hole that I think is probably, maybe a little better at a longer presentation, but my hope is that we'll be able to use these funds to find some other dollars that we can leverage for some of the programs where we can show that it's going to be sustainable ongoing. If we can't show it's sustainable, I don't think we should bring it to you. And I'll just be plain about that. I don't think we should be coming forward with programs. Now, some of this funding grows out 3 years, right? So we do have quite a bit of it. So we will have a planning horizon where we can have the discussions, particularly through a budget process, about what we may or may not want to support. Childcare is a great example, but I think that's a continuing conversation with you all, right? And this committee and A&R, what is it that we think we should do moving forward that is sustainable from a budget perspective? Because if it's not sustainable, it doesn't have that impact long term. So we have to focus on those things that are one time, or those things that maybe there's a cost for doing some restructuring. Now's our opportunity, right? Now's our chance. This funding will allow us to do some restructuring, but if we do that restructuring, it has to be sustainable over the long term. So you make a very good point, and we have to be cognizant of that. But I think that's this continuing conversation that we have with you all.
And I appreciate that. Again, I don't have a good sense today of which direction we're heading, and that's, again, no criticism of anyone, but that's probably discussions for future meetings in this group as we try to figure this out. But
right.
When we look at future funding, I hope we really give a priority to things that I've embraced before, one being that we improve the health of our population. I don't think our MCOs have done a very good job of that with our systems. And secondly, reducing the number of people who have to rely upon Medicaid by improving our economy. Of course, we got to work hand in hand with our Cabinet for Economic Development and certainly Department of Education. But to me, that should be two of the strongest measures. The success in any program we do Have we improved the health, and have we removed people off of Medicaid through gainful employment?
And yes, sir. Completely agree. And I hope you heard through this that we're talking about some career pipelines to getting people, through careers, some of that entrepreneurship, right? We do, in all of this funding, I think we have to be cognizant of, right now we have some broken pipelines, right? So we have to figure out how to make those connections so that folks can progress, right, through higher paying jobs, in an economy that we hope and we think is really positioned to boom.
Well, I would agree with you that a lot of this seems to be held together by twine and duct tape. I would suggest adding a little WD-40 to your toolbox, and we'll see if we can get through this. Thanks, sir. Appreciate your time.
Thank you.
We're going to shift to remote now, and Senator Berg, are you there?
I am here. Thank you very much. Very interesting discussion. You all can hear me okay, right?
Yes, ma'am.
All right. Very interesting discussion. I think in part, it goes, and I want to make sure this point is made loudly and clearly. It goes to the fact that we have undervalued childcare in this country forever. So, when I hear you saying that you're trying to promote entrepreneurship and people with, private daycares, I'm thinking you're setting these people up to struggle financially for the rest of their lives because we don't pay childcare workers enough to sustain a private practice model as far as I'm concerned. So one of the things I would like us to consider going forward is legislation that actually would help us and help working parents cover the cost of reasonable childcare, which is something, that as a working mother was never available to me in the past and should be available to working families in this Commonwealth in the future. That's one comment I wanted to make. So thank you.
Thank you, Senator Berg. Is that all the remotes? Okay. I have a question, and then we'll go on to the next subject. My question is, we've used contact tracing and testing, and this has had an overall cost associated with it when we mitigated the COVID, and it's been significantly decreased. Has the cabinet had a free of any formally designated dollars? And if so, where's it been allocated to?
No, the COVID tracking, tracing, testing, that's pretty much all been federal dollars. It's so big, we haven't been able to repurpose those dollars, particularly in those areas. Eric, do you?
No, we have used coronavirus relief funds for testing and then what specific federal grants that we've received. And now that testing and tracing is on the downward slope, the dollars that have been passed are moving into vaccinations. Yeah. And that's the direction that things are going. But we have not supplemented any general fund dollars with our testing. All the testing has been focused on coronavirus, and they've been supported with federal funds.
Let me give you a little example. Nursing facilities, right? We have probably provided well over $100 million worth of testing and supplies to nursing facilities across the Commonwealth. And that's true for a lot of folks, but that just kind of gives you an idea of the scope. And really, that's not something we were doing before at all, and we wouldn't be able to do without the federal funding support. So that's all like 100% federal funds.
Okay. Thank you, Secretary and Mr. Lowry, for your presentation. Next, we're going to hear from Commissioner Lee on implementation of HB 183, the hospital funding bill. Commissioner, are you out there? And please identify yourself for the record. And again, members, hold your questions till after the presentation, please.
Hello, I'm here. I am Commissioner Lee, Lisa Lee. I am the Commissioner for the Department for Medicaid Services. And if you have your presentation in front of you, we have a combined presentation with implementation of House Bill 183 and also Michelle P. and SEL waiver program information in that presentation. But if you go to slide 7, it's where the House Bill 183 begins. And on slide 7, we just want to point out a few little things about managed care directed payments. So House Bill 183 is a mechanism that will allow the department to pay hospitals the average commercial rate. Those payments will be sent through the managed care organizations, and as such, CMS views this as a directed payment, which is a little bit different than just creating a state plan amendment to allow this process to happen. We actually have to submit a preprint to CMS. And in this preprint, we have to outline the payment methodology, how the MCOs are going to be paying the payments to the providers. And we also have to list out quality measures that will be evaluated during the course of the payment, the enhanced payments. Typically, these the preprints are submitted on an annual basis. However, we have worked with the Kentucky Hospital Association to submit a 3-year preprint for the Acr program, which we'll get into a little bit more. But the main reason for talking about the directed payments is just to give you an understanding of the process, and that CMS doesn't just allow us to mandate managed care organizations to pay a specific amount to provider types unless we have those quality measures in place and we're monitoring going forward the impact on the program. So House Bill 183 is the Hospital Rate Improvement Program, or HRIP. On January 14th of 2021, CMS approved a revision to HRIP, which significantly increases Medicaid reimbursement to private Kentucky hospitals. We will be paying them the average commercial rate rather than the upper payment limit methodology that we've used in the past. The increase in payments will help advance the quality of care of Medicaid members and provide a stable financial base for hospitals that will extend beyond the financial challenges of the COVID-19 pandemic. We have continued goals of improved access to care and lowered hospital readmissions, but we've also expanded the quality measures to include two opioid-related metrics, because we know that the opioid epidemic is still a major issue in the Commonwealth and does dramatically impact a large number of Medicaid members. House Bill 183, CMS did approve our Acr Reimbursement Methodology retroactive to July 1st of 2020. It is currently approved through June 30th of 2021. And however, we have collaborated, as I said earlier, with KHA and submitted a request for a 3-year approval process. And that was submitted May 11th of 2021. And again, the cabinet, all of our medical professionals in the cabinet did collaborate with KHA to develop those quality measures in the preprint to make sure that we're moving forward in a manner that it's going to improve the health status of individuals in the Commonwealth. We have made payments for the 2021 HRIP. As you can there, in April, we paid $246 million. And on April 15th, we paid $246, and then on April 30th, we paid another $248 million. Recently paid another $250 million, and have an estimated $250 million payment that will be going out in August. And as you can see, this is quite a significant amount of money that we believe is going to have a positive economic impact in our communities, in addition to assisting with us improving the health status of our state. So that is the update on House Bill 183. I'd be more than happy to take any questions that you may have.
We take questions from the room first. Senator Meredith.
Thank you, Commissioner Lee. You always do a great job in your presentations. I appreciate the information. Mine's a very simple question. On slide 9, you see hospitals cover the increased state costs of the program. Do you have a price tag for that?
They will put up the state share, which is, or their assessments, they pay assessments, but if you look at about billion that we'll be getting in from the federal government. They'll pay about 10% of that, I believe. But I'll double check with my chief financial officer and get that information back to you.
Is that handled like the provider tax is?
Yes.
So it'll be calculated similar to that, and contribution be made based on basically the same criteria?
It's based on their discharge basis. It's paid on a per discharge basis. It's how it's calculated.
All right, thank you. Thank you, Mr. Chair.
Commissioner, your microphone is just off just a little bit there. We can't hear you.
Can you hear me if I lean in a little bit more?
Yeah, that's better. Thank you very much. Anyone else have a question? Remotely, do we have any questions? Well, I'll ask one then. What is the status of the request for a 3-year reapproval?
That is pending with CMS currently.
Okay. And what's the timeline for that?
I'm not sure. If it depends on if they have specific questions and they come back. We have been having conversations with CMS. We don't anticipate any issues with it. And as the example from the 2021s, you can see it was retroactively approved. So there shouldn't be any issues with the break-in service if you're concerned about the June 2021 end date of the current approved process.
Okay. Thank you, Commissioner. And this time we go on to the discussion of the Michelle P. and Supports for Community Living Waiver Programs. Commissioner Lee and Pam Smith, as Director of Community Alternatives, will be speaking. And again, identify yourself for the record. And members, hold your questions till after the presentation. Thank you.
I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services, and I will hand this presentation over to our waiver expert, Pam Smith. Pam, please introduce yourself and proceed with the presentation.
Thank you, Commissioner. I am Pam Smith. I'm the Division Director of Community Alternatives, and we are responsible for the oversight of our 1915C home and community-based waivers. On slide 2, we highlight some information on the 4 other waivers. I realized this specifically was about Michelle P. and SCL, but wanted to highlight some information just about the other waivers as well. And of note, we now do not have a waiting list for any waiver with the exception of SCL and Michelle P. We worked very hard to allocate those slots in the brain injury waivers to get rid of those waiting lists. On slide 3, we go into more detail about Michelle P. and SCL. Michelle P., as you know, we have 10,500 funded slots. Our wait list at this point is above 7,000. At the time of this presentation, when we were gathering the data, we were at 7441. We are in the process of allocating 175 additional slots. Those, we hope to have them sent out this week. There's a large process that goes into that with verifying addresses and making sure that those actually get to the recipients. So it takes a little bit of time for that process to completely work through, but we are allocating those. We have been allocating slots for Michelle P. About every 90 days for over the last year to try to get us up to that point. As you can see, right now we're serving actively 10,156 individuals. Those 149 slots that are reserved are actually individuals that a slot has been allocated to, but they have not received an assessment yet. They have not reached out to one of our CMHCs to conduct that assessment. We provide follow-up on that for 90 days after we issue the slot. And if we are not able to locate the individual, or if they decline wanting an assessment at this time, we are able to allocate that slot back out again. Once they have an assessment and access even 1 day of services, then that slot is used for the rest of the waiver year. So our plan is to continue allocating those slots every 90 days. For SCL, we are up to 4,786 that are actively being served. We have 30 slots that have been allocated but have not yet completed the process. So they're waiting on either their assessment or they're waiting on to get to actually access services. We still have a 0 on the emergency waiting list. There's 121 on the urgent waiting list and 2,765 on future planning. It's important to note, and I'll talk a little bit more about the wait list on the next slides, but those that are in future planning really are those sometimes that sign up even when they're a toddler and they know at some point in time in their life they are likely to need waiver services. But at any point in time, anyone on the urgent or future planning wait list can request review for emergency status. On slide 4, to talk about just some generals about our waiting list. So for Michelle P., the average age of the individual on the wait list is 16. 73%, so over 5,000 of the individuals are less than 21 years of age. 15% of the individuals that are on the waiver are accessing services in another waiver. The majority of those are in the home and community-based waiver at this time, although we do have some that are on SCL but have chosen to remain on the wait list for Michelle P. The average time on the waiting list is 3 years. However, the oldest that anyone has been waiting at this point is 6 years. We add an average of 78 individuals to the waiting list each month. Since the beginning of 2021, we've already allocated 350 individuals. And as I mentioned, we are in the process of allocating another 175 individuals. When we look on slide 5, some additional details about our SCL waiting list. So the average age of the individual on that wait list is 30 years old. 90% of the individuals are accessing services in another waiver, and the average time on the waiting list is 7 years. For SCL, we add an average of about 30 individuals each month to the waiting list. And since the beginning of 2021, we have allocated 13 emergency slots. And to wrap up, I want to talk a little bit about our ongoing work that we're doing for the 1915C waivers. I'm going to come back to Appendix K and talk about it last, but our Model 2 waiver renewal, it was at the end of its 5 years and had to be submitted for renewal. It actually is with CMS for review following its formal request for additional information. And we actually are meeting with CMS excuse me, on Friday to discuss that waiver. Our home and community-based waiver renewal, again, had ran through its 5 full years, and so it was due for a renewal. We have it right now and are working through responding to the formal request for additional information with a target date to return it to CMS, hopefully by the end of this week. EVV implementation has continued and monitoring has continued. We've seen anywhere from 26 to 50 to 60% adoption rate of the providers. It depends right now a lot on the providers and the populations they serve. Many of our participant directed providers have been using it 100% with all of their participants for at least 30 to 60 days now. We are beginning our plans to resume our on-site provider certification visits. During COVID, and especially during its peak, we were very careful about the sites that we would visit. We only went on site if there was a health, safety, welfare concern. All other certification events took place virtually, and we did a lot of desktop reviews. So the team now is just getting ready to go out to finish those things that must be done on site and in person. And lastly, I'm going to talk about Appendix K Flexibilities. So our last renewal with CMS, we received approval for that to remain in effect until 6 months after the end of the public health emergency. So once that has been declared over, that will allow providers time to transition back to normal services. But to highlight some of what we have allowed through Appendix K, we issued retainer payments to adult day and adult day training sites that had a loss of over 50%. That totaled just a little over $5 million. We allowed additional providers to provide home delivered meals, and we saw a tremendous increase in home delivered meals as a result of that. We've also allowed for overtime in some of the programs, and allowed, if an individual goes into the hospital and the hospital is not able to meet their acute medical needs, or for example, they have a communication barrier and their staff may be able to understand them, but the hospital wouldn't be able to, we will pay for those providers to be able to go and provide those additional services to ensure the health, safety, and welfare of those individuals.
Thank you, Commissioner and Ms. Smith. First, are there any questions from the members here in the room? We have one from Representative Prunty.
Thank you, Mr. Chairman, and thank you for your presentation. On slide 5, you mentioned that 90% of the individuals are accessing services in another waiver. Can you elaborate on that? Like, what other services might they be getting? Are they Medicaid funded waivers? What would constitute them? Do they need both? I mean, can you give us an example?
Right. So some of the individuals in particular that are on the future planning wait list may be receiving home and community-based services. So they have family that are still able to be involved, that are still able to provide some natural supports and some care for them to a point that they don't need residential, or their needs are being met without needing that emergency SCL slot. Many times they also are accessing state plan services. But the majority of those individuals are receiving HCB, which means they have also, in addition to an ID or DD diagnosis, they have a medical comorbidity that's being treated. There are a few individuals that are on Michelle P that have elected to stay on Michelle P because, again, they have family or natural supports that are able to meet their needs right now, and they do not need the intensity of the SCO waiver.
Okay, thank you. And can I follow up? On the EVV, are there trainings for those folks? Because I had one constituent who was actually a former patient. The caregiver was not tech savvy, and if the home health nurse hadn't been there to help her with the phone, she might have quit the job. So I just wondering if the EVV, if there's supports there for those individuals to learn how to use that.
There is a specific employee training that was done for Kentucky individuals specifically. Some of the other trainings that our EVV vendor has done were more just global, so it went over just basic functionality. But we realized early on that number one, our individuals are used to a very hands-on approach to training. So we've developed a lot of quick reference guides that we've actually shared with other states and they're using, but we also offer one-to-one sessions with either individuals or providers where we're able to actually look at their data, look at the application, and go through specific scenarios for them to help them to walk through it. So if you hear of any of that, encourage them to, if they will reach out to us, we do offer that one-on-one support.
Thank you. Thank you very much. Thank you, Mr. Chair.
Senator Carroll.
Thank you, Mr. Chairman. Pam, in specifically addressing Michelle P. waiver, have you all done any data collection in relation to the types of services that, let's say, recipients below the age of 18 and then above the age of 18 on what services are primarily being used? And then along with that, have you all considered any discretion in perhaps giving adults more of a preference in certain situations to get the waiver services? And I know, and the reason I ask that is more, with younger kids, especially those that have more family supports, the waiver may not be as critical as it would be for some of the older people who apply. What conversations have y'all had in that area?
So absolutely understand your question. So we are in the process right now of evaluating the services in each waiver and the utilization. I looked at first step for Michelle P that we've looked at is how many of those individuals, in addition to the ones that the small percentage that are receiving other waiver services, how many are eligible for Medicaid and what state plan services are they receiving. We're looking at that part of waiver redesign when we are able to resume that. When we do look at that, we had talked about just in general looking at the whole wait list process there. And SCL right now is the only one that really has a triage of different levels. So looking at really how do we roll that out to other waivers, and looking at, again, as you mentioned, what services are those children receiving, and is there a different way for them to receive those services? If they're Medicaid eligible, are they available through state plan? And just maybe the providers aren't aware. So really focusing too on provider education to make sure that they understand, if you have an individual who is eligible for waiver, it's not just the waiver services they're eligible for, that they need to look at them holistically and also look at what services in the state plan could meet their needs.
Okay. And as we look at more of an a la carte type services that are more specific to the needs of each individual, will that create any savings where we might be able to perhaps serve more people if we're being more specific on the services, more efficient in the application?
Honestly, it's too early in the research to tell, but that is the intent as we look at this, to understand how can we begin to, is there a way that we can begin to serve more individuals that are on that wait list? Though we are still very early into looking at the reporting, so I don't want to make any wrong assumptions until I've had time to completely look at the data.
Okay.
And this is Commissioner Lee again. If I could just add to that, Senator Carroll, that we have a lot of interest in the 10% funding that is going to be coming through the department as it relates to HCBS spending. We're going to have some additional funding coming through that we will need to have state appropriations for. And we have actually polled, and when I say we, I really mean Pam, has polled providers and members to see how we can best use those funds. And you heard Secretary Friedlander talk about career paths. We're looking at using some of those enhanced funding for training for some of our providers. We're also looking at ways that we can have short and long-term goals to improve the waiver programs, the services that we provide. And I think this is just a first step in actually taking a really good look and a deep dive into those programs to find out how we can strengthen those and make them sustainable in the future, because our waiver programs are the trajectory of the cost for the waiver programs continues to increase for that population. So I think it's a really good idea to take a step back. As you know, the previous administration started the waiver redesign, and we put a pause on it because we had a lot of concerns from providers within the community related to the way that we were going to restructure the program to make it budget neutral. Some providers would win, some providers would lose. And if we move forward with the plan as proposed without adjusting some of those payment methodologies, we'd need an infusion of approximately $43 million into the waiver programs in order to complete that redesign. So as part of our enhanced funding that we're going to receive, we are looking at the waiver redesign to see if there's bits and pieces that we could pull out and implement with that one-time funding that we have to strengthen these programs. And again, our overall objective and goal is to make this person-centered planning so that each individual gets the necessary supports and services that they need. And it's just not carte blanche for everyone. Just because you can have so many therapies doesn't mean that you require it. It all has to definitely be medically necessary and be based on a person-centered plan of care.
I might have to interrupt here. We got 5 minutes for 2 more questions, and then we're going to save time for Ms. Stay back there to speak. So Representative Frazier, make them brief, and then Senator Meredith, and then we'll go to Amy Stay.
Thank you, Chairman. This is a question that I'd asked Secretary Friedlander earlier, and he thought that you all might be the better ones to answer it. But providers in the home and community-based waiver program have not received any communications on potential assistance or relief. And there's several active day centers. One's closed in Richmond and apparently 2 others in rural areas, mainly because of lower reimbursement and strict delivery method. And I would just like to know what the Cabinet's plan is to help the adult day centers because they're struggling.
I can defer to Pam, but I believe that we issued a total of about $5 million in retainer payments to adult day centers and adult day treatment centers. So I'm not sure, which facilities have reached out to you, but we have issued retainer payments. And Pam can speak a little bit more about Appendix K and how that assisted those providers during the COVID period.
So we did, you're right, Commissioner, it was about $5 million in retainer payments. A large bit of that actually went to active day providers. It makes me sad to hear anytime that we are losing a provider, and encourage them to reach out to us to see if there's anything that we can do. The other thing that we've done for the adult day providers is we allowed them to branch out into both telehealth services and providing services in the home. We do have actually our largest in-home provider for HCB is an adult day group. And I believe actually in the top 5 that 3 of them are adult day healthcare groups that are actually providing in-home services to individuals. So we're continuing to try to expand the services that they also are able to offer to allow them to, have additional additional inputs for revenue, additional ways really to serve our individuals.
Thank you.
Senator Meredith.
Thank you, Mr. Chair. Just 2 brief questions, and they're going to sound rhetorical. I don't mean them to be, but COVID certainly has wreaked havoc on our workforce, and healthcare is not an exception. But do you have any anecdotal experiences of people having disruption of service because of the lack of personnel?
We actually, in the recent surveys that the Commissioner mentioned, we targeted that question specifically. And we required critical incident reports to be submitted to us if there was service interruption, or if individuals tested or were exposed to COVID. And we, from the overwhelming response we received from the participants themselves, is they did not feel like that it had impacted them. Some of them felt like there were a mild service disruption, but not that it impacted their ability to feel safe or taken care of. That was something that we were concerned about, because honestly, a lot of our individuals, the waiver staff are their natural supports. They're their only support. So it was something that we kept a very close eye on, and that we worked to help them get access to vaccines, and allowed our case managers additional units to be able to help find vaccine locations, to help find transportation, to help with that. So
good. That's encouraging news. Second question I have for you, and it's really broad in scope, is what single thing can we do as a legislature to help these programs?
Funding.
I knew that'd be the answer. Just wanted to hear you say it.
I keep saying, if somebody would tell me where the money tree is, I'll go shake it. But honestly, I mean, it really boils down to funding.
Understood. Thank you. Thank you, Mr. Chair.
There's none remotely. No. Okay. Thank you, Commissioner and Ms. Smith. Amy, if you'd like to come up and introduce yourself. Amy Stay is the Executive Director of the Kentucky Association of Private Providers, and she's going to speak here and speak in A&R also. So
yes, thank you so much. Is the mic on? Can you hear me?
Should be.
Okay. Thank you so much for allowing me to be here. My name is Amy Stade. I am the Executive Director of the Kentucky Association of Private Providers. We are a trade association representing providers of 1915C waiver services to individuals with intellectual and developmental disabilities. We have over 100 provider members in our trade association, and collectively we support 10,000 individuals with intellectual and developmental disabilities in the Commonwealth. I am coming back at 1, so I'm going to go through some of this pretty quickly, especially because Director Smith addressed kind of a lot of what I wanted to talk about, but I did want to hit upon a couple things that have come up. So if you go to, and I'll share it in just a second. Here we go. So, prior to the pandemic, 1915C waiver providers, they've struggled for a long time to recruit and retain employees. It's always been a struggle, but the pandemic's made it a lot worse. And so CAP, as a provider association, did a survey in May 2021, and it revealed 2 things. Providers have been significantly impacted in revenue and workforce. So 91.3% of respondents reported that they'd experienced a significant reduction in revenue directly related to the pandemic. The average lost revenue is $682,000. These are waiver providers. They're not billing hundreds of millions of dollars per year. So $682,000 for a provider that's operating on paper-thin margin and generally has less than 10% capital in the bank is significant. And to your point, this is why we have seen providers close up shop. So 54% of respondents reported that the greatest challenge that they're currently facing is recruiting and retaining staff. 86% of those respondents reported that they've had difficult recruiting and retaining staff despite offering enhanced wages, overtime, bonuses. They've used their PPP funds for this. They've done everything possible to try to keep these staff, and it's not gone well. So of that 86%, 77% are residential providers. This is significant because our residential providers have literally been providing 24-hour-a-day, 7-day-a-week care since the beginning of the pandemic. This is shift work, and to Pam's point, to Ms. Smith's point about the survey they sent out, they asked the question, have you been unable to either access or provide a service because of staffing issues? And I'm going to tell you, most providers are going to answer no, because they're required to provide a service, especially residential providers. If they've made it work, despite the short staffing, despite the critical understaffing, they're required to have staff there for these individuals. They could be charged with abandonment if they just left someone unattended and without staff. So I don't know if the responses to that question are completely paint the full picture, but only 2.8% of respondents to our survey said that they're fully staffed. 2.8% of all waiver providers. 50% are critically understaffed, and the rest are understaffed but making it work. Because of this understaffing, we've had significantly increased overtime. Providers reported an average of $22,000 in overtime alone just during their last pay period, their last 2-week pay period. So as I said, Dsp turnover has been a problem. Direct support professional, that's our caregiver staff. It's been a problem for a while, but it's gotten worse because of COVID. Why is that? Well, 1 is low wages, and 2 is the emotionally demanding nature of the work. It's hard work, it's emotional, it's exhausting, and unfortunately, waiver providers, because they are 100% Medicaid reimbursed, they can only pay what the rate supports. The Navigant survey that you've all heard about revealed that about $10 an hour was the going rate. That was in 2018, and I'll tell you, since then, it's actually gone down because providers are so understaffed. They're having to implement lower starting wages, knowing and understanding that everybody's going to get overtime. So they're implementing the lower starting wages because of the significantly reduced overtime costs. And it's a huge burden. So this turnover problem, it impacts everyone. It impacts individuals with disabilities. A recent study by the Council on Quality Leadership shows that high turnover impacts the health, safety, and welfare of individuals with disabilities. It results in increased critical incidents, hospitalizations, and ER visits, which we all know are very costly. And it does, especially in our consumer-driven options, it affects individuals' ability to recruit and retain their own staff. It impacts providers. As I said, we've got critical staffing levels. We've got significantly increased overtime costs. And there's significant costs in these programs with onboarding new hires, which is something that's not talked about. So when you have high turnover, you're constantly hiring new employees. We've got background checks, we've got training costs, we've got drug screens. All of those the providers have to pay for out of pocket, and they're not reimbursed for that by Medicaid. And those costs are significant when you're doing it pretty frequently. This also has an impact on wait lists. Providers right now have reported to me that they are turning down referrals despite having capacity because they do not have the staff to care for people. So we're never going to meaningfully address our wait lists if we don't first address our workforce crisis. We have to build out the workforce infrastructure if we're ever going to address these wait lists and make sure that the individuals that are most vulnerable citizens, get the care that they need. So just some policy considerations as we think about moving forward. Workforce is the most critical portion of our HCBS infrastructure. If you think about a bridge, workforce is the pillars that holds the bridge up. Without the direct support professional workforce, there can be no community-based HCBS services. It's as simple as that. Institutional care is costly. The per diem, the average per diem for institutional care is about $1,200 a day. Community-based care is $215 a day. So we are saving a lot of money, and we're providing better care in the community. And again, the most prominent contributor to our HCBS workforce crisis is wages. These providers are 100% Medicaid funded. It is impossible for them to just raise wages. Without a corresponding rate increase, they can't do it. My providers would love to pay their employees $15 an hour, $20 an hour. They'd actually be able to recruit and retain qualified, highly skilled employees to provide this care, but they can't pay that much. The rate simply does not support it. Additionally, 1915C waiver reimbursement rates are rarely adjusted for inflation. In fact, they've never been adjusted for inflation. Only one waiver has ever gotten a rate increase, and that's not to place blame anywhere. We understand that funding's tight, but we have got to add a wage component onto our rates that adjust for inflation so that these providers can raise wages. Right now, what we're seeing is through all workforce, every McDonald's is raising wages, Walmart's raising wages to keep up and recruit. These providers can't do that. These are not minimum wage jobs. They're highly skilled care positions. And right now, they're only able to pay about minimum wage. And so no one wants to work in that stressful environment, working long shifts, working mandatory overtime, when they can go work at Starbucks for $20 an hour and get free coffee. So here are our recommendations. Number one, we need to utilize these one-time HCBS ARPA funds to invest in the workforce. We agree that there need to be some long-term system investments and some one-time uses of the money that can make some system fixes. But if we don't save this workforce and invest in the workforce, there's not going to be a care system to invest in the future. And then we need to implement a long-term funding strategy in the next budget that targets the workforce. We have budget language to do that, that I'm happy to talk more about in depth at another time. We have budget language that we have put together that would specifically issue rate increases to specific targeted services where this workforce is a problem and require a pass along of 75% to the employees, and even to satisfy you all and help, making sure our dollars are being used well, even have a reporting and oversight mechanism built into that so that we ensure providers really are passing along the money. I know that was fast, but if anyone has any questions, I'm happy to address them.
You did very well. Yeah, I'm presenting. Thank you. We have about 5 minutes left for questions. Representative Waiver.
Thank you, Mr. Chairman. Amy, I do have one question for you. Would you say that the $300 additional of pandemic unemployment assistance that folks are receiving in the state, is that contributing to your inability to recruit and bring in workers?
Yes, I would say that it does.
Okay. I wanted to ask that, Mr. Chairman, to get that on record. When I was working on a bill during the last session on unemployment taxes that would be paid, I met with you to discuss the impact it would have on nonprofits. Generally, what we heard at the time is how it would affect employers who were making profits. But that measure also had an impact on nonprofits as well. And one of the things we discussed when I met with you was when one of these facilities closes their door and no longer is able to provide a service, it has a domino and a ripple effect that actually costs more for the state of Kentucky to provide assistance for the individuals that utilize those services. So I appreciate you coming here today. I think this is something that's important, and I just wanted to get that on record because we have to do something in this state to get people to return to work. And I know that it has been suggested by the governor that when Chairman Pratt and I submitted a letter to him asking him to end that program, that we would cut that off immediately and leave Kentuckians with no option. We've never suggested that, but we have to have a plan. And right now I don't see a plan moving forward. So I appreciate you coming. I appreciate you answering that question. This is something that we have to seriously look at, and folks in this state have to begin to take seriously. Thank you, Mr. Chairman. Thank you, Amy.
Representative Moser. Brief.
Yes. Thank you, Mr. Chair. Thank you, Amy, for your presentation. I appreciate that you came with recommendations, and we're happy to look at that. I have a question that hasn't really come up, but it just occurred to me. We're talking about a lot of nonprofits in this space, but these are state-mandated services. And so when they're not able to, when our providers are not able to adequately hire or staff these positions and care for these really high need individuals, who accepts the liability if there's a staffing issue and something horrible happens because these individuals weren't cared for? I mean, these are state mandated services.
Unfortunately, the liability falls on the provider. So, for example, if we have a residential provider who has 10 houses and 5 staff, they can't get any more staff in, and they can't borrow staff from another agency, and they have to make the tough choice to leave someone alone or unsupervised for an hour, and something happens. That provider would likely be shut down, likely be probably charged criminally, definitely with abuse and neglect.
Yeah, so the ripple effect is potentially really not only dangerous to the individuals being served, but will likely close down our providers. Sure. So thank you.
Senator Carroll.
Thank you, Mr. Chairman. Amy, I think it's safe to say that it's the residential providers who are struggling the most right now, the 24/7. The day program's probably somewhat faring better. And I know with PPP and all that stuff, with our organization, that's really helped to get us through. But we're different because we provide a lot of different services for children and adults. So that's kind of a different scenario. final question, with the waiting list for the waivers, especially Michelle P., we have noticed in the past that one of the biggest issues we face is a lack of a new population coming into our facility. Are we still seeing that throughout the state? And how much of a financial impact do you think that in itself is? I mean, these slots, we have so many people on a waiting list that can't get the services, therefore they're not getting in to see these providers, and it's affecting the business. How much of an impact do you think that has today?
It definitely has a significant impact. And just to address kind of the two comments that you made, first, I would say yes, residential providers are struggling the most with the staffing portion. Our day service providers are struggling tremendously with revenue. They've been the ones who have hit hardest with revenue. Initially, they had been closed at the beginning of the pandemic, and we proposed actually to Medicaid in a coalition letter that significant funds be set aside for lost revenue for these types of providers, and specifically $10 million for adult day health care centers to help them. To address the second portion of your question, yes. So as you allocate more slots, you increase a provider's ability to see more people, to touch more lives, which can increase revenue and help with staffing, et cetera, things like that. But in order to meaningfully address these wait lists and get more people into the programs, touch more lives, help more people, we have to have the workforce. So you have to address, it's a two-pronged approach almost. For example, in a budget cycle, take a 2-year budget. Year one, you use the money to address the workforce. You build up the workforce while also allocating slots, but you hold off the allocation of the slots until 6 months later when you've built up the workforce and can actually have the space and you actually have the manpower so that people can access services. Because you don't want to get into a situation where you're allocating slots that no one can access.
Thank you.
We're going to cut the questions off now because we ran out of time and they're telling me I have to clean the room and that type of stuff. But she will be back for A&R at 1 o'clock. And Senator Berg, I haven't forgotten you. I knew you were out there. So if you would text her question, we'll get an answer to you for sure. Okay?
No problem. Thank you.
Okay. So before we adjourn, members, again, please note that remote access will be allowed to all meetings for the interim. Members will be provided the information prior to the meeting on how to access the meeting remotely, and the meeting materials will be made available online for downloading. The next scheduled meeting date available is July 7th. So do I have a motion for an adjournment? Motion and a second. So we are adjourned. Thank you. Very good meeting.